Good morning everyone, and welcome to Applied Epidemiology for Healthcare Managers. I'm Professor Pirouzi, and over the next 12 weeks, we're going to build your capacity to understand, interpret, and apply epidemiological thinking in your roles as healthcare leaders. Now, you might be wondering, why does a healthcare manager need to understand epidemiology? Isn't that for researchers and public health officers? Let me tell you, in today's healthcare environment, epidemiological literacy is not optional. Every decision you make about resource allocation, program planning, quality improvement, and population health management is fundamentally an epidemiological decision. When the COVID-19 pandemic hit, healthcare managers who understood epidemiology were able to interpret the data, anticipate surge capacity needs, and communicate effectively with their teams and the public. Those who didn't were flying blind. That's the difference we're building toward in this course. Let's start with the fundamental question: what is epidemiology? The classic definition comes from John Last's Dictionary of Epidemiology, the study of the distribution and determinants of health-related states or events in specified populations, and the application of this study to the control of health problems. Let me break that down. Distribution means we're looking at who gets sick, where they are, and when illness occurs. Determinants are the factors that influence whether someone gets sick: risk factors, protective factors, causes. The key distinction from clinical medicine is that epidemiology is population-focused. A clinician treats the patient in front of them. An epidemiologist asks, why did this patient get sick while others didn't? What does this case tell us about patterns in the broader population? For healthcare managers, this population perspective is essential. You're not managing individual patients, you're managing systems that serve populations. Understanding epidemiology helps you ask the right questions: which populations are we serving well? Which are falling through the cracks? Where should we invest resources for maximum impact? Epidemiology has a rich history, and understanding it helps you appreciate the power of epidemiological thinking. John Snow is often called the father of epidemiology. In 1854, during a cholera outbreak in London's Soho district, Snow mapped cases and identified a cluster around the Broad Street pump. He convinced authorities to remove the pump handle, and the outbreak subsided. This was decades before germ theory. Snow used epidemiological reasoning to identify the source without knowing the biological mechanism. Ignaz Semmelweis, working in Vienna in 1847, noticed that maternal mortality from puerperal fever was much higher in the ward staffed by medical students than the one staffed by midwives. He hypothesized that students were carrying cadaverous particles from the autopsy room. He instituted handwashing with chlorinated lime, and mortality plummeted. Tragically, the medical establishment rejected his findings, and Semmelweis died in an asylum. Florence Nightingale wasn't just the lady with the lamp, she was a pioneering statistician who used data visualization to advocate for sanitary reforms in military hospitals. Today, we saw epidemiology in action during COVID-19. The concepts we'll learn are zero attack rates, case fatality rates, contact tracing, moved from academic journals to daily news. As healthcare managers, you lived through this. Now we'll build the framework to understand it systematically. Epidemiology doesn't happen in a vacuum, it happens within healthcare systems. Understanding the Canadian context is essential for applying epidemiological thinking to your work. Canada has a universal single-payer system, often called Medicare. The federal government sets national standards through the Canada Health Act, but healthcare is administered provincially. This creates both opportunities and challenges for epidemiology. The Canada Health Act establishes 5 principles: public administration, comprehensiveness, universality, portability, and accessibility. These principles shape what data we collect and how we can use it. The Public Health Agency of Canada, or PHAC, coordinates national surveillance, responds to outbreaks, and provides epidemiological expertise at the federal level. They publish the Canada Communicable Disease Report and maintain national surveillance systems. At the provincial level, public health units, there are 34 in Ontario alone, conduct local surveillance, investigate outbreaks, and implement prevention programs. As healthcare managers, you likely interact with your local public health unit regularly. This multi-level system means epidemiological data flows between local, provincial, and federal levels. Understanding this flow helps you access the data you need and contribute to the broader surveillance picture. Let me introduce some foundational concepts we'll build on throughout the course. Population at risk is the group of people who could potentially develop the outcome we're studying. If we're studying ovarian cancer, men aren't in the population at risk. Defining this population correctly is fundamental to calculating meaningful rates. Incidence and prevalence are often confused but measure different things. Incidence is new cases over a time period, it measures the risk of developing disease. Prevalence is existing cases at a point in time, it measures the burden of disease. A disease with high incidence but short duration might have low prevalence. A disease with low incidence but long duration might have high prevalence. Risk factors increase the probability of disease. Protective factors decrease it. Epidemiology identifies these factors through systematic observation and analysis. Causation versus association is a critical distinction. Just because two things occur together doesn't mean one causes the other. Ice cream sales and drowning deaths are correlated, but ice cream doesn't cause drowning. Both increase in summer. We'll spend significant time on causal inference. Bias, confounding, and chance are the three explanations we must rule out before concluding that an association is causal. Understanding these threats to validity is essential for critically appraising evidence. Let me make this concrete for your roles as healthcare managers. How will you actually use epidemiology? Needs assessment and program planning require epidemiological data. Which conditions are most prevalent in your catchment area? What are the trends? Where are the gaps between need and service availability? You can't plan effectively without this foundation. Quality improvement is applied epidemiology. When you track surgical site infection rates, analyze patient falls, or monitor readmission rates, you're doing epidemiology. The methods we'll learn: calculating rates, identifying risk factors, evaluating interventions, apply directly to QI. Resource allocation decisions should be evidence-based. If you're deciding between investing in diabetes prevention versus cardiac rehabilitation, epidemiological data on disease burden, risk factors, and intervention effectiveness informs that decision. Outbreak investigation isn't just for public health. Healthcare-associated infections require the same epidemiological approach. Contact tracing, identifying the source, implementing control measures, these are epidemiological activities. Health policy advocacy is more effective when grounded in data. When you're arguing for resources or policy changes, epidemiological evidence strengthens your case. Decision-makers respond to well-presented data on burden of disease and intervention impact. To do epidemiology, you need data. Let me orient you to the major Canadian health data sources you'll encounter. The Canadian Institute for Health Information, or CIHI, is a treasure trove. They hold data on hospital discharges, emergency department visits, physician billing, prescription drugs, and more. Their public reports provide benchmarking data you can use to compare your organization's performance. Statistics Canada conducts major health surveys including the Canadian Community Health Survey, which provides population-level data on health behaviors, chronic conditions, and healthcare utilization. The Canadian Health Measures Survey adds physical measurements and laboratory results. Provincial health administrative data includes everyone's interactions with the healthcare system, hospital admissions, physician visits, prescription fills. Researchers access this through provincial data stewards, but summary statistics inform planning at all levels. Cancer registries systematically collect data on all cancer diagnoses. The Canadian Cancer Registry compiles provincial data nationally. Similar surveillance exists for reportable infectious diseases. Primary care electronic medical records are an emerging data source. Networks like CPCSSN, the Canadian Primary Care Sentinel Surveillance Network, aggregate de-identified data from participating practices to track chronic disease trends. Knowing these sources exist helps you ask better questions and know where to look for answers. Epidemiology involves collecting and analyzing data about people, which brings ethical responsibilities. Privacy legislation governs health data in Canada. PIPEDA applies federally, but provinces have their own health information laws, FIPA in Ontario, HIA in Alberta, and so on. Understanding these frameworks is essential when you're accessing or sharing health data. Research involving human subjects requires Research Ethics Board approval. Even program evaluation and quality improvement sometimes crosses into research territory. Know when REB review is required. Indigenous data sovereignty is increasingly recognized. The OCAP principles, ownership, control, access, and possession, assert Indigenous communities' rights over data about their peoples. If your work involves Indigenous populations, engagement and partnership are essential, not optional. Health equity must inform epidemiological work. Data often reveals disparities, by income, geography, race, gender. Responsible epidemiology not only identifies these disparities but works toward addressing them. Data without action can perpetuate inequity. Communication of findings requires care. Statistics can be misinterpreted or misused. As healthcare managers, you'll often translate epidemiological findings for diverse audiences. Do so accurately and responsibly. Let me give you a roadmap for our 12 weeks together. Weeks 2 and 3, we'll dig into measures of disease frequency, incidence, prevalence, mortality rates, and measures of association, relative risk, odds ratios, attributable risk. These are the building blocks of epidemiological analysis. Weeks 4 through 6 cover study designs. We'll start with descriptive epidemiology, case reports, case series, cross-sectional studies. Then move to analytical designs, cohort studies, case control studies, and the gold standard randomized controlled trial. You'll learn when each design is appropriate and how to critically appraise them. Weeks 7 and 8 tackle the hard stuff, bias, confounding, and causal inference. How do we know if an association is real? How do we move from correlation to causation? This is where epidemiology gets philosophically interesting. Weeks 9 and 10 apply epidemiological methods to specific contexts, screening program evaluation, disease surveillance systems, and outbreak investigation. These are directly relevant to healthcare management. Weeks 11 and 12 bring it all together with applications to healthcare quality, patient safety, and health services research. We'll work through case studies relevant to your roles. By the end, you'll be able to critically read epidemiological literature, ask better questions of your data, and apply epidemiological thinking to management decisions. Let me summarize what we've covered in this first session. Epidemiology is the study of disease distribution and determinants in populations. It differs from clinical medicine in its population focus and its emphasis on prevention. For healthcare managers, epidemiological literacy is essential. Whether you're planning programs, improving quality, allocating resources, or responding to outbreaks, you're making epidemiological decisions. The Canadian healthcare system provides rich data sources through CIHI, Statistics Canada, provincial administrative data, and surveillance systems. Knowing these sources helps you find the evidence you need. Ethical considerations must guide your work with health data. Privacy legislation, research ethics, Indigenous data sovereignty, and health equity are not obstacles, they're principles that ensure our work benefits the populations we serve. This foundation supports quality improvement and healthcare planning. The methods we'll learn are immediately applicable to your roles. For next week, I'd like you to read the assigned chapter on measures of disease frequency and identify one example from your workplace where you've seen incidence or prevalence data used, or should have been used, in decision-making. Questions. My office hours are Thursday afternoons, and I'm always available by email. See you next week.